opportunities, and I think this law really moves that along.
Okay. I have a couple of questions myself of the panel.
Thank you. I just want to go back to, I'll give those to Mady. I'm Steve Rosenberg, if anyone doesn't know that by now. I want to go back to Dave Mancuso's study that he found before lunch, and I want to frame that as a challenge to you all. If what David showed is with a select group of folks in Washington who were childless adults, who were exposed to the criminal justice system, by providing them with substance abuse and behavioral services, the Medicaid system was able to save money, and presumably we didn't even count the amount of money the criminal justice system was able to save. I think the question for all of you is, how does that scale? Okay, so I think that we have the data that shows that this is a great investment, and I appreciate all of what you've been talking about the pockets that we have of experience that have demonstrated to us that this can work. I think the challenge I'd like to pose is January 1st, 2014 is not very far away. And how do we scale this knowledge, this expertise, and the DM data bit that demonstrates the cost effectiveness of these? These are challenging budget times, and I think that's where David's data is so powerful.
Can I take a crack?
Yes.
Because I think we're already seeing some scaling right now. In several states, I spend a fair amount of time traveling and talking to both state governments and mental health and substance use authorities, as well as to provider organizations. And I think what we're beginning to see is state governments, I'll use Missouri as an example, just did it just now, looking at their highest users of Medicaid costs, right? So if you take your 5,000 highest users, and you look at their involvement in substance use, and of course we know that the criminal justice system is full of people who have a history of substance use disorders. If you look at that and you then add other physical illnesses that go along with that, and you add the mental illnesses component, and you say as an authority, as a state government, your governor's office says, your Medicaid office says, let's serve those people and let's hold those providers accountable. We'll give them a decent rate to create what literally is a medical home. Right now, figuratively, literally, as medical homes get rolled out, and the guidance yesterday has just started around Medicaid and medical homes. And so you will now, I think, increasingly see organizations, whether they're healthcare organizations or behavioral health organizations, have single points of accountability to manage the overall health expenditures of particularly high-cost individuals. And I think that's how you're going to get to scalability, is because Medicaid authorities are going to need to be accountable for it, and that risk will flow downward. And you're going to see organizations hold that risk and be accountable.
And I think at the county level, you have, if I was a county board chairman, if I was a county board president, I would be having the same conversations with the justice system because I fund them. And I would be encouraging them to then come together and work with the substance abuse treatment community with their own strategies for identification and referral to community services, and they will create the demand at the local level and the incentive at the local level and the savings at the local level to fund expansion on a county level for service delivery. So I think there is the state level Medicaid strategy that will drive some of this, and then the justice systems locally, which are not really controlled centrally from a state perspective, will have to also come to the table and plan and strategize if they're going to take advantage of the opportunities that emerge as a result of ACA.
So, go ahead.
It's also incumbent upon the local providing network or provider network to come together locally and make a determination about what the goal is. Is it the 5,000 highest users or the most complicated cases? Which organizations are best able to address those needs and to build on each other's strengths? Not all organizations are able to do the same thing, even organizations of the same type. It is to honestly face each other and say, I do this best. I'm going to do that. I'll take this piece of it, because we're all responsible. I'll take this piece, you take that piece, does this work? It has to happen there, because we talk a lot about insurance coverage. That does not provide access, and it certainly does not provide the right access. And it's incumbent upon the local community to make that determination and try to work together.
I also want to add just one thing, which is, we're talking a lot about the changes that need to be made and the kind of collaborations, and I do think they're well underway. I think the other thing is we have to continue to struggle with the limits of our technology, and I don't just mean HIT technology, which I think is a vital piece of this, by the way, but I mean in terms of our treatment technology. We have a great, robust list of evidence-based practices, but those will change over time as we create new evidence. And the engagement and effective treatment of people is still a struggle. One of the things I say to our members is don't invest in real estate, because when you're talking about people who are underserved, you're really talking about people you've got to chase. You've got to be willing to do it, and you've got to work at engagement. And the other thing behavioral health organizations have to do, and we need state mental health and substance use authorities to realize this, is we have to stop closing cases. We've been under tremendous pressure. If someone doesn't show up for 30 days, close the case, and really you're actually assessed against that. Well, my primary care doctor doesn't close my case because I haven't showed up in 30 days. I don't have to start all over again when I show up going through my history. So I think there's practice change that has to go along with it, and we have to have our regulations keep up with that and actually enable it.
Hi, Carol McDade. I'm with Capital Decisions from here at Washington, D.C. I have a comment about some of the advocacy I've heard today, and then a question. Not on this panel, but actually with the help of many on this panel and many of the organizations in this room. I've been a federal advocate and worked for quite a while to try to get the parity law and the Affordable Care Act passed, with some of the gains that we've talked about today for people with addiction and mental health problems. And I've been concerned to hear some of the way that it's been messaged today about what's not covered under those laws, what services aren't covered, what particular groups of people aren't covered. And I guess a lot of us have gone to a lot of trouble getting legal analyses done by legal action, by other law firms, that really clarifies what's in the law, who's covered, that a continuum of care that's comparable to the medical side is covered. And I think as we think about what type of advocacy positions that we're taking at a time when we are working really hard to get regulations on parity done that clarify what requirement and what type of continuum of care is required, that we not negotiate with ourselves in writing or otherwise when we have an administration who tends to be very favorable with us on these provisions. And that as a matter of course, when we have these sort of issues where we have questions and concerns, that we do that in a way that doesn't undercut our advocacy positions that we are fighting for tooth and nail as we speak right now, both on parity regs and on the drafting of the essential benefit package for health reform. People obviously are not waiting for 2014, and that work is going on right now. And I know that these are all very interesting intellectual questions, but there's a difference between intellectual and advocacy. And so I guess my other comment would be that there's a lot of work that's going on by a lot of the organizations who have spoken this morning about the getting ready for all the new changes that are going to come. And we seem as a field to be really good at sort of either doing advocacy or getting ready for systems reform, but we don't seem to be good at doing both at the same time. And that's what's critically needed right now. I guess, Linda and Mady, if either of you could talk about from your and Pam, from your long history with the field, how can organizations both get ready for systems change and stay focused on the advocacy we need to get these laws actually implemented and not give up right when we get them passed?
Good question.
Good question, it is.
And you know, we should acknowledge the role Carol McDade played in not only the passage of parity, but in having parity included in healthcare reform. So.
Yeah. We will, as this discussion goes on, Carol, we will get to your question.
Gary Filerman, Atlas Research. I want to get back in part, connect a few dots here, in part to Steve's point about scaling up. It strikes me that all of this structural scaling up and the changes you've been talking about ring hollow when we really look at the realities of the workforce situation. Between the community health centers and the jails and the supply of physicians and nurses and social workers and so on is a huge gap, which these comments about the law providing support for primary care and so on don't begin to close. And the time frame is totally out of sync with what you're talking about. This is totally unrealistic. We are awash in wishful thinking. And I would suggest that there is another agenda item that you've got to address, this community must address, we don't have enough now, called scope of practice, which is a structural inhibitor between effective utilization, cost containment, access. It's a local issue, it's a state issue, it's something that we all shy away from getting involved in because we're going to piss off the social workers and they're going to screw up the nurses and so on. But until the professions step forward or the employers step forward and say, we've got to deal with client-centered task allocation and not 100-year-old definitions that are obsolete of professions, we're not going to solve this problem.
And as the moderator, I will take a point of privilege and say I couldn't agree more that scope of practice and workforce issues are a delimiting factor in bringing to scale what we all hope for. I wanted to ask the panel a question that has to do with what you think states and counties know now, this minute, about who the populations are that are going to be eligible for benefits in Medicaid expansion or under parity. Who are these individual people? What are their demographics? What do they look like? Are they, because they will have just received benefits for the first time, sicker? Are they less sick? Are they employed? Are they unemployed? Who are they? And what should that have to do with how we're thinking about scalability and taking this national?
I think there is a lot of work actually going on in states around that. Certainly Kaiser has led looking at the demographics in each state, who the populations are. I think we know that among the indigent uninsured, there is a far higher incidence of mental illness, substance use, and chronic physical conditions that have gone untreated. So I think we do know that. So, although I can't tell you what each state looks like, I think that's part of the planning that's beginning to go on at the state level with the departments of insurance as well as health departments and behavioral health leadership.
Hope so.
And what I would say is that I think that the states and counties know who these people are. They know they're being served in their jails and their prisons. They know they're being served in their psychiatric hospitals and their substance treatment programs. They know they're in their homeless programs. So they know the people. Do counties, let's say, because I think on a state level with substance abuse, Medicaid, directors, Department of Insurance, people are planning and better informed. I'm not sure the county government, unless it's a really strong county-funded substance abuse treatment system, is thinking about this yet, other than to think maybe there's some hope for us, and we can shift some costs to the federal dollar. And I think realistically, you know, one of our challenges, kind of to Carol's point, is to enlist more advocates and more people invested in this as an opportunity for change in how business is done, how services are funded, and who gets coverage, and ultimately then the health of communities. And so Don Murray, wherever you are, you were here a minute ago. I think that's a group of people that we can and should be tapping into for advocacy on these issues as well.
I think they are disproportionately uninsured, underserved, whether they have insurance or not, minorities, and insufficiently addressed with regard to how do you get them into the system. Just knowing who they are, it's nice. It's a wonderful thing to know, but there are some outreach, if you will, one of those old terms that people didn't want to talk about for a while. There's some outreach efforts that have to take place, and you need to know what those are and try to address them, and have the entities that do that best do that and bring them into the system of both primary care but also behavioral care.
I have a question from the floor first, and then I'll go to the back. Under ACA, how will homeless individuals with substance abuse and/or mental health disorders be able to access health benefits if arrested? How do you create a health home without a home?
Okay, absolutely right. I mean, I think one of the things we have to realize is the ACA is necessary, but it's not sufficient. I mean, it is not a housing program, and was not intended to be. And I think making the point that people are not going to recover if they don't have a home is an essential point. We have another agenda, and maybe Steve will bring us together again to look at the whole issue of housing and where our advocacy is around housing and housing subsidies for poor people generally, and then specifically for people with criminal justice involvement.
There was a question in the back.
I'm Michael Botticelli. I'm the Director of Substance Abuse Services for Massachusetts. And just a couple quick observations and then a question. So first of all, we already have a state that has health care reform. So I'm in a very fortunate position that we have a great Medicaid benefit, and all of our exchange programs cover substance use services. That said, however, part of my concern, particularly as it relates to this population, is that we still can't keep up with demand. And quite honestly, I think the concern that we have is without a serious infusion of resources, that particularly on the criminal justice side, we spend a lot of time increasing capacity within our system to handle those folks in the criminal justice system. However, I think we've gotten to the tipping point where just about the only way you can get into the community-based system is through the criminal justice system, and it's a really perverse incentive, quite honestly. So we want to make sure that not only do we have resources on the criminal justice side, but that we keep people from entering into the criminal justice system by providing them treatment early on. So that's just one point. The second point, I couldn't agree more with Linda. I think we have pockets of excellence. I hope that Massachusetts is one of them. I think a lot of the work that we've been doing with community health centers has been proven to be tremendously effective in, one, attracting newer clients to treatment. So these are not people who will walk into a detox program, but they'll walk into a primary care office. And I think that is astounding in terms of our ability. I think, however, that that's only been accomplished through strong strategic partnerships with the State Substance Abuse Authority, right? And I don't think, and I want to say we have valuable resources on the state level that know how to do this. And I think we need to rely on the state substance abuse agencies to partner with community health centers and other primary care settings, quite honestly, to do this work. The last is a question that, being from Massachusetts, I probably shouldn't ask, but I'm going to ask anyway. So to what extent do you, so I don't know what the provisions of the Affordable Care Act are as it relates to behavioral health carve-outs for the provision of behavioral health services, and to what extent you think carve-outs either help or hinder integration with primary medical care. I won't offer my opinion because I'll really get in trouble.
Not me.
Go for it.
I'm very brave, maybe. You
Okay,
know that.
go for
I'm
it.
very
Go for
brave.
it.
It's interesting, and let me, I have a note to myself to talk a little bit about managed care, because managed care was never uttered during the healthcare debates, right? Because everybody hated it, providers and consumers. But the truth is, these new benefits, these new people who get benefits will be managed. Managed care companies are on the move. And in this audience, we have some not-for-profit managed care companies, but most of them are very much for-profit. And even in Massachusetts, the contract that the state has with one of the companies, who then downloaded the general healthcare management to a carve-out, has made access very tough. And this goes back really to Carol's point about advocacy. You know, we're better advocates when we're advocating with government than when we're advocating with for-profit companies. They don't necessarily have to listen to our advocacy. And we need state authorities to craft contracts that make access to all needed services the law of the day, and then we have to be willing to help consumers and their families take it to court if necessary. And that really goes to kind of Carol's point I think she was making about can we do implementation and advocacy at the same time. So I think for me, this is really, so it doesn't matter whether it's integrated and then they subcontract it to a carve-out, which is what they do, because some of these are so complex that integrated, managed care companies won't manage it themselves anyway. I think the real issue is, will they enable providers and health centers and behavioral health providers to provide the services that are really needed, and will how they do business encourage those collaborations at the point of service. You can reorganize up here all you want. If you don't improve things at the point of service, you're not going to change your outcomes.
And will they insist on accountability? Again, you can organize all we want to do, but is there an expectation around accountability? Not just assignment to where you go, who sees you, what the discipline is, but did you make a difference?
And I think that was the point of medical homes and accountable care organizations,
absolutely.
was to move that accountability as close to the consumer as possible.
Exactly.
Because it is about outcomes. And you can say something's integrated, and it's not. You can incentivize integration, and it doesn't happen. You can, and you can, but if you focus on outcomes, and if you align your strategies and your goals and your incentives, your contracts, et cetera, along the lines of outcomes, you'll get integration where you need it. You'll get collaboration where you need it, because people will do what they need to in order to get paid for better outcomes. And it is at that client level, I think, that you'll see the difference about it.
And if you aren't so wed to your integration, collaboration format that you're unwilling to make changes that are automatically happy in communities, to say you no longer can do that, because while you were part of the big integration, collaboration scheme, nothing changed with your clients. And as a result, what we're prepared to do, whoever we is, the Accountable Care Organization, the state, we're prepared to make changes in whether you can deliver a certain set of services.
And on that note, we will end this panel and move on to the next. Thank you so much.
Thank you.
All of you.
Thank you all very, very much.